thanks for being here. Um, so yeah, I know I've been talking to Marianne kind of about what you've been doing up to this point. It sounds like you're kind of you have a lot of you're gaining a lot of knowledge on health literacy, organizational health literacy, and kind of clinical health literacy, and kind of how health literacy impacts individuals. So I'm here to kind of talk more about kind of the numeracy impact and impact on healthcare. Because if you think about numeracy, it's a very large concept. It not only talks about just numbers itself, but risk, and what does risk mean to people, and how do you communicate risk if you're a provider, and how is that risk kind of perceived when you're a patient or a research participant. So there's a lot to go through here. Again, before I begin, I don't have any other financial interest to disclose other than I work at the Detroit Mercy Law School. So my goals really for today are hopefully you'll be able to kind of explain how the numeracy skills that patients need in healthcare, and kind of the negative impact of this, and then kind of understand some of the best practices for these type of things. And then, again, depending on your role, I'm seeing all the roles listed in the chat, your kind of how this impacts you is going to be different, right? If you're the one doing the communication or creating some of the communication that others read, that's going to be that's going to be a different impact than if you are kind of one of the leaders of an organization, kind of figuring out how are the processes that we have set up, how are those how are those geared to kind of help with this problem area of numeracy. So we all have a problem with numbers, especially in my field of the law. There's I teach law students all the time, and there's like, I came to law school so I wouldn't have to worry about numbers. But unfortunately, you can't get away from it, because that's just kind of the way, the way things go. No matter what, there's going to be some type of, probability or considerations that come into, almost anything you do. And so that's kind of what we're going to focus on today. And so, you've already heard about low literacy in the US, but in fact, low numeracy is worse than that. So this is from the main study on literacy, and the main recent study, which is the PIAC. But anyhow, this particular graph focuses on 16 to 19-year-olds. So the point of that, of course, is that when we have a lot of the next generation, they're going to struggle with low literacy, but they're going to struggle even more with low numeracy. So whether that's something that is kind of endemic to our education system, or just kind of our culture, it is what it is. So we just are going to have to deal with that. So if you think about the general literacy statistics, you've heard about those with the null data and other data that you've heard. And again, we've got basic literacy and below basic literacy. And I'll talk a little bit about what the quantitative literacy levels mean here in a few slides, but we're worse within that. So if you think about it, 55% or so are only basically, able to do minor calculations and kind of understand what numbers mean and those type of things. That's kind of the gist of that slide. Whereas, 44% or so, or 43% have basic or below basic health literacy. So from a prose standpoint. So I think it's helpful. We generally talk about the main literacy, low health literacy statistic, but that can be broken out into a lot of different categories, from prose to quantitative to, document literacy. How do you find your way through a multi-page document? There's a lot of different components of literacy. So risk communication is something that I like to talk a lot about too, because it's, obviously that's one part of communication in general, but that's where a lot of the numbers come into play. So it kind of goes hand in hand, with numeracy. So kind of how do you help people understand the nature and seriousness of a certain action so that they can make an informed decision? So it's not only all the other stuff that we kind of inform, patients about, but, how can we make those numbers make sense, or at least mean something to folks? That's kind of what I think about when I think about risk communication. And so if you think about numeracy, it includes what's called minimal statistical literacy, right? Because a person's ability to interpret and use numeric information requires them to be able to kind of make a medical decision based on percentages or, fractions and kind of, the likelihood of something happens. So so that's kind of what we focus on when I talk about minimal literacy. Statistical literacy focuses on the main concepts like absolute risk rather than more advanced topics like, some of the stuff that statisticians actually do. So it's kind of that minimal statistical literacy, being able to understand and make choices based on this information. So if you think about the easy to difficult stuff, so that basic and below basic category, those are basically being able to identify numbers and do, minor computational things, simple manipulation of numbers and, addition, subtraction. Once we get into multiplication and division, it kind of gets up into the next level. But you also have these analytical and statistical kind of problems with numbers, right? Not only what do these numbers mean, but how can we estimate, what's going to happen, to a population with just a smaller sample size and those type of things. Proportional, understanding proportions and probability and risk, and so this can go from just basic numbers all the way up to some of the more difficult things that we might even struggle with. So you think about quantitative demands in health literacy, they come up all the time. You think about dosing. That's the obvious one that we tend to think about. Oh, people misread their dosages and take too much or too little or something like that. But you think about monitoring weight, BMI, all of that type of stuff, checking temperature, using nutrition labels, insurance plans, right? Having to calculate your budget and figure out, okay, well, if I, is the copay, going to eat up a lot of my monthly budget, and, kind of deciding different plans and those type of things. Understanding lab work and kind of, whether the numbers fit within a certain range. Managing insulin, diabetes type things, blood pressure, interpreting risk, it could go on and on. We could really go with just list 100 different things. But if you think about labels, that comes up a lot. If you think about whether a person's healthy or not healthy, you kind of look at labels and you're kind of figure out whether something's good for you or bad for you. But in a study, again, from 2005, study of diabetics, all that at least had a high school education, 71% of type 2 diabetics and 41% of type 1 diabetics were unable to use a nutrition label to calculate carbohydrate grams based upon serving size. And that's important, obviously, when you have diabetes or other types of conditions that might force you to kind of look at labels and those type of things. So we know that what's out there is, the numbers and kind of the way that we present it is not really resonating with a vast majority of folks. And if you think about numeracy skills, and I kind of created this slide with with kind of some examples in mind, but another study of infant caregivers with diverse demographics, 99% had adequate literacy skills. So this is caregivers, but only 17% had a better than 9th grade numeracy skills. So I use percentages there. Right. The next one, though, I use 1 in 4. So kind of like proportionality. 1 in 4 couldn't properly prepare a dose of prescription medication or read a digital thermometer. And then half, notice how we're talking about numbers even in this slide differently. And I did that on purpose, of course, but that's what happens a lot in documents when we're kind of, giving folks, medical information, let's say about the risks in colonoscopies, or should you do this instead of the other thing. We're often kind of mixing up numbers like this, using percentages one point and proportionality the next, and then just general, spelled out words instead of numbers in a third, in a third instance. And so, we might think, oh, that's easy. People can just add, can just go from percentages to, to fractions to something else. But that actually makes it a lot more difficult. And then comparing the numbers and kind of thinking about, how they're related is a lot harder to do with that. So what I did on this slide is not what you're supposed to do. You should, pick one and stick with it, but frankly, but mostly it's kind of that natural frequencies, 1 in 4 people, 5 out of 10 doctors or something like that, as you hear about it. 9 out of 10 doctors would recommend this toothpaste or whatever. That resonates better than other types of numbers. And so if you think about other studies, there's been a lot of studies, thankfully, on numeracy, but almost half, or 46% of patients, misunderstood common dosing instructions. Um, and some of these are not necessarily related to, numbers, right? It's like, oh, I took too much or I took too little. Some of it is because of the wording that's on, that's on the label. Like, for example, my father-in-law, both my wife and I kind of grew up poor. And so, when we think about low health literacy, and, we were the first to go to college and all of that. So we have everybody near us in our extended family. So my father-in-law, for example, I can't remember the specific medication he was taking, but it was some type of pain medication. And it said something like, take 2, every 4 hours or as needed. And so we were over there one night, and he was kind of a little out of it. And we're like, why, you're kind of a little bit out of it. Well, how many of those have you taken? Well, I took 8. Why? Because it said as needed and I needed them. And so it's like, okay, well, as needed doesn't mean take 8 in, a 4-hour span or something like that. It means take 2, as many, every 8 hours. But then if you don't need them anymore, don't take them anymore. Not the other way around. But that's the problem when we think about how numeracy, the numbers, but also kind of the wording kind of work together. This was something, again, this was a number of years ago that I took this picture, but I was giving, I think it was one of my kids at the time, giving them Augmentin, or maybe it was somebody in the family. But I was reading these instructions, and again, I talk about numeracy a lot, and I'm like, this is crazy. So think about this: tap the bottle until all powder flows freely. So here I am tapping the bottle. All right, I'm tapping. What am I doing? Add approximately 2/3 of total water for reconstitution. So I got to know what 2/3 mean, for one, but I have to also have to know what reconstitution means. Now, I'm a lawyer. I know what the Constitution is. But reconstitution, a lot of people will be like, that doesn't make any sense. But just in case you didn't know what 2/3 meant, you definitely are going to bold that and say 67 milliliters total, because that means a lot to me. Most people think in milliliters, don't we? And of course we don't. And so that was just kind of interesting, kind of mix of different numbers, but also just not very health literate in the first place. And then this is something my wife got when she went to the eye doctor. And I think about this. Look at this. Instill 1 drop by ophthalmic route. What the ophthalmic route? Okay. So now I have to guess what that means if I don't know what ophthalmic means. Does that mean in my eye? I think so, but most people would not know it. Ophthalmic route 2 times every day into the left eye. Okay. And then the next one, instill 1 drop. Notice instill is spelled differently. Instill 1 drop, and wrong, by the way, to the right eye once daily. So the number 1 and 2 are used the first time, but the spelled out number 1 is the second one. And then again, instill spelled differently again. Instill 1 drop into the left eye twice daily. And then the last one, instill 1 drop into the right eye once daily and left eye twice daily. So everything's different. So you know what happens. Whoever's putting these into the EMR or the EHR, it's different people, different times, and they might spell it wrong or they're doing it fast. But there's not consistency there, and that can cause trouble. But ophthalmic route, that was another one. There's other ones with where you use the medical jargon and it's OU, like both eyes. Like, I don't know what that is. This was another thing, so I kind of on the health portal, we pulled this up, I think for my wife's uncle or something like that. And he let us look at this, uncle or aunt, I can't remember. But anyhow, so you see this: weight 85 kilograms, height, and now everybody knows what a kilogram is here in the US, don't we? Height 5'8", BSA 1.99. See all these numbers, it doesn't mean anything to people. So there's literally every day, if you just start looking for numbers and how they might impact somebody's health or something like that, you're going to find them. And again, this was something I like this, reacted to so eye-opening. I just saw that. Very good. But you think about Chantix. This isn't bad, because this is one of the things that you can do. So this is the Chantix instruction. So weeks 1 through 4, reduce your smoking to 1/2 of your starting daily number of cigarettes. That might by itself, if it just had that, might be confusing to people. Well, 1/2 of what? I don't really know how much I start with. But then you have an example. If you smoke 20 cigarettes each day, reduce your smoking to 10 cigarettes each day during weeks 1 through 4. So that's one of the things we can do when we have numbers, is kind of give an example of how it works, or do the math for them in an example, just like this. And then you see the next one. It kind of reduce your smoking to reach 1/4 of your starting daily number of cigarettes. By itself, I'd be like, it'd be hard to figure out what that is. But again, if you have the example that kind of explains things, that can help. So that's one of the things we can take away from this, is that sometimes you just can't get away from the numbers or explaining what people need to do. So that's the thing that I don't want people to take away from this, is that, well, we just have to avoid numbers altogether. We can't do that, but we can do things to make it more understandable, and like these examples and other things like that. And I'll talk more about those as we go. So now you don't have to type these in, just think to yourself the answers to these. So a person taking drug A has a 1% chance of having an allergic reaction. If 1,000 people take drug A, how many would you expect to have an allergic reaction? So think about that. And then we'll have another one. A person taking drug B has a 1 in 1,000 chance of an allergic reaction. What percent of people taking drug B will have an allergic reaction? And then the third one, imagine that I flip a coin 1,000 times. What is your best guess about how many times the coin would come up heads in 1,000 flips? Now, I didn't make these questions up as you're thinking about these. This was actually part of a study, and the results are these. So the first answer is, of course, is 1% chance of having an allergic reaction. That's 10 persons in 1,000. So 30% of a representative sample of folks missed this. Now, if you missed that, that's fine. But the next one, a person taking drug B has a 1 in 1,000 chance of allergic reaction. What percent of people? That's the hard part is people don't turn things into percent very well. So 0.1 is the answer, because it's 1 in 1,000 and not 1 in 100. And so people don't, forget to move the decimal point. And then again, only 24% of the people miss the, flipping a coin. And again, to get that right, you have to know what a coin is. You got to know it's heads or tails. There's 2 options. So there's a lot of kind of things that you have to bring to the table. And so, just these things, when you stop and think about it, you can get these. But the problem is we don't often stop and think. We just kind of answer, and that's what people do. Now, this was given to doctors. And so here, assume that you conduct breast cancer screening using mammography in a certain region. The following information about the women in this region. The probability that a woman has breast cancer is 1%. If a woman has breast cancer, the probability that she tests positive is 90%. If a woman does not have breast cancer, the probability that she nevertheless tests positive is 9%. And so based on that information, these doctors were given this question. A woman tests positive. She wants to know from you whether that means that she has breast cancer for sure, or what the chances are. What is the best answer? A, the probability that she has breast cancer is about 81%. B, out of 10 women with the positive mammogram, about nine have breast cancer. C, out of 10 women with the positive mammogram, about 1 has breast cancer. Or D, the probability that she has breast cancer is about 1%. So I read them because I know you can read them, but to give you more time to answer. And the answer happens to be C. Out of 10 women with a positive mammogram, about 1 has breast cancer. And so don't feel bad if you got that wrong, because most gynecologists who were studied with this grossly overestimated too, based on that data. So you see before they were given training on natural frequencies, you see a lot of people chose 90%, the first one, or I think it was the second one, but then the rest, 18% or 13% chose 81 and 19% chose 1. And then after they were kind of given training on some of this numeracy, they started thinking about it and said, slow down, let me ponder this. And most kind of now understood, okay, well, I've got to think about, natural frequency. So translating these conditional probabilities into, 1 in 1 in 100 women, or 90 out of 100 women, or those type of things. It's a lot easier than kind of saying percentages or decimal points and those type of things. So there's many great resources on numeracy, so I put some links in here, and again, you'll have the slides so you can look at these, that will give you suggestions, examples for communicating these type of things, because that's really, depending on your role in the organization, that can be important. How do you roll this type of thing out if you're kind of one of the leaders in the organization, or like I said at the outset, if you're the one actually doing the work, then some of these other resources are helpful for how to do that. So kind of getting back to risk communication a little bit. Again, it's more than just the numbers themselves. It's a lot about what we communicate, how much patients want to know, when we communicate it, but also how do we communicate? So risk is more, so when you think about risk, you often think about lawyers, and that's my type, and everybody doesn't like that, and you're like, well, what do we need to say that's legally required? That's what we tend to think about as lawyers, but yet it's much more than that. It's not telling you what to do. It's more like, it should be patient-centered. What matters to you? How can we go about making this decision in the best way possible? So the shared decision-making stuff and a lot of the other health literacy things that you've been learning really applies here as well. So when you communicating risk is more than just, again, the legal risk. It's considering the patient's needs and their limitations. What does risk mean to patients, right? We know what risk means to us. If we're the provider or we're the lawyer, we have a different focus on risk. But to patients, it can be, what can go wrong? What are the chances it will go wrong? What do these numbers mean for me? In my situation, I'm not a smoker. I'm not a person with high hypertension or something like that. What does it mean for me? What will my recovery look like? What happens if complications arise? All of these other things. And so I like the last one. What is most important to me in this horrible looking set of documents you gave me? That's what we're trying to avoid, obviously, with health literacy, but that's often what people are thinking. Just tell me what's important so I can look at. So when you think about risk communication, the way that we organize information is important. We don't want to bury key information. And again, Marianne said, talked about me being on the FDA's Risk Communication Advisory Committee. I was on that until 2022. But one of the things that pharmaceutical companies have to create, you might have heard black box warnings. That's what these are called. They're actually called, in order to get a black box on there, the pharmaceutical company has to go through and create a REMS, which is a risk evaluation and mitigation strategy. And the FDA uses these when it determines that the additional safety measures are needed because these are risky drugs or risky whatever, whatever it is that's maybe it's a biologic or something like that. So it's risky scenarios. So the main point of a REMS is to communicate risk, right? And so you're like, oh, of course, if that's the main point, when I see a REMS document, the risk should be obvious. Well, consider the mindset of those creating the REMS, right? The goal is to get the food, drug, cosmetic, whatever it is, approved. Their lawyer's main goal is to protect the organization. The patients and consumers are secondary, right? Maybe they would not say that, but that's kind of what it feels like. But here's a REMS, because you can find these REMS. They're publicly available documents. So I pulled this, a number of years ago off of the FDA's website. So here's a REMS again. So it's something that's given to the patient. You see it, patient agreement. And so you'd think it's a REMS. They're going to start with risk information. Well, instead they start with this. The patient care program will collect and use your information in the following ways. And all of the first, basically half of the page is all about risk information. How we're going to use your information. This is how we're going to protect it. This is how we're going to use it. That type of thing. And the risk stuff, the reason you're doing the REMS is buried here at the end. My doctor has explained the risks. I have received a copy of the guide. I understand that I'll be observed at the clinic for 3 hours after each injection. Now that may be something I would like to know. I've got to go and get an injection and then sit there for 3 hours. Don't bury that in the middle of the page. Someone must go with me to the destination when I leave the clinic. So that's another thing that's important. So anyhow, and then again, they get back into the last few points about, again, more about surveys and information. But the real reason that the FDA required the REMS was for this information that's buried in the document. So I often think about that. Why would you do it that way? It doesn't make any sense. But probably because, and this is just my speculation, because you're more worried about complaints over information disclosure than you are about risk of the treatment. Or because you don't understand what is important to patients. That's probably part of it too. Or because you need to get this done quickly to comply with FDA regulations and meet company objections. So probably a little bit of all of those. But what's missing is the patient focus, the patient-centered discussion of these type of things. And so when I think about numbers, I think about how patients learn, so, and how do I convey difficult information, risks, numbers, that type of thing. We know people don't read things and think in precise details and facts, right? We do this all the time. Think about outside of your job, when you get home and you look at mail or email or whatever, and you look at something, you're like, do I even open it? How many times have you just ripped something up and thrown it in or recycled it or whatever? I do that for the most part for all the things that look like junk mail. But I get something, let's say from a hospital, or maybe it's a bill or something like that, and I open it. I don't really want to read it from front to back. I don't have the mental energy to do that. So I'm kind of more skimming. What does this mean? What does this mean to me? Is it something that I should pay more attention to? That's more of the fuzzy trace theory, this gist-based thinking. So that's what people think. What's the bottom line for me? But yet, too often, what those that create it are more like, oh, we need to say this specifically because people will pay attention to this. It's important to them. You might not, you don't know if it's important to them or not. You just think it's important to them because it's important to you. So that's what I usually do is focus on gist-based messages first that include calls to action, that get people's attention and relates the message to everyday language. And then if there's legal requirements that you need to say that you haven't already covered, or there's other data or something like that that needs to be in there, well, you can reinforce those gist-based messages with more specifics later. And hopefully that information is easy to understand too. So when I think about risk, and how do you communicate it, I think about the way that you organize the risk information. So something that's called risk hierarchies. It's simply a guide for prioritizing and ordering the information based on the needs of the audience. So for patient-focused documents, this means I'm prioritizing what's most important to patients first, and then including whatever else you feel needs to be included to protect your organization or by law or whatever, instead of like we saw with the REMS, which was, this is what's important to us. Oh yeah, then we'll put the patient stuff later or in the middle. Do it the other way around. So how do I create a risk hierarchy? And again, I don't often say, well, let me create a risk hierarchy. I'm just thinking about this. What's most important? I consider the intended users and learn about their needs. I might need focus groups. I might need user testing. I don't always know everything, and I don't pretend to know everything. And so you got to ask people. Write down the information that your intended users want to know in from these focus groups or whatever. Rank that information from most important to least important to them. You can have them do that in these focus groups. And then after you do those important things to the patients, you can discuss any other information you need to disclose by law, or that your org wants to discuss. And add those into the bottom line of the list, only move it, or the bottom of the list, only move it up if the law requires it, for example. So the important things come first, the kind of the required things or the organizational interest in things come later. And so this was a better REMS. Again, you can pull it up. So we don't have to read the whole thing, but basically everything on the left side is all about the risks, and I'm aware of these risks, and this is what has to happen. I need to have blood and urine tests within 30 days. And then the things that are more kind of informational type risks, data type risks are kind of put over on its own side. So starting with the things that matter and then ending with the things that are kind of required or important to the organization. So it's not all bad. So how do you handle some of the numeracy issues? So this is more of the, some of the takeaways of the best practices. Well, again, order is important. I start with the most important information, to the patient again. I group information, figures logically, some type of, by some type of category, so it's, if it's all, women versus men, well, maybe I'd have all the stats for women, on one side, men to the other, something like that, some type of logical grouping. Remembering that less is more, statisticians and researchers and PhDs and doctors might want all the specifics, but not so much, patients, not so much. Sorry, you can hear my dog barking there. All right, so then you further explain complex topics. Remember, numbers don't do it all. They still need words and kind of, frequently asked questions, those type of things to help do that. Numbers for one idea at a time, trying not to mix different things, so if I'm only talking about risk of cancer from this drug, well, I don't want to bring in other risks at this point. And then again, underscore the gist of each piece. What's the takeaway? What's the takeaway message? Sometimes you don't have to do that, of course, if it's pretty easy or straightforward, but the more difficult it is, the more important that becomes. Rounding and denominators. So I've thought about this more than I think I fight about anything else with numbers, because again, doctors, statisticians, lawyers, we're pretty precise, and there's some value into being precise. But if we know that patients, don't really appreciate the difference between 78.64% versus 79, or even about 80%, if we know that people prefer that, why don't we give them what they want? And then if you must include the decimal, well, then put that in parens after it or something like that. But lead with the patient-friendly version. The biggest thing I could say too, though, is with, especially when you're doing like natural frequency, 1 out of 10 people, keep the denominators consistent. Don't switch between 1 in 10 or 1 in 5. I often do that to my students. Quick, what has a higher chance of death, 1 in 10 or 1 in 5? And people think, oh, 1 in 10, that's just natural. But really, that's 10%, whereas 1 in 5 is 20%. So keeping the denominators consistent makes it easier. 1 out of 10 people, 2 in 10 people, that's easier to kind of compare. The way that we frame messages or explain, use the words, it can subtly influence decision making. And so that's a bad thing, when we're trying to present things neutrally. So here's an example. If you're favorable to a certain treatment, you'll say, with this treatment, you'll have a 90% chance of survival. But if you aren't, if you kind of want to subtly push people away, you might say, with this treatment, you got a 10% chance of death. And that's going to sway people. And so if we're trying to be neutral, which we should, I provide both positive and negative frames to eliminate any subconscious bias. 90% of the people who were studied survived, but that means 10% suffered, died, or maybe say death in a better way, but kind of presenting both, so that way that way you feel like, oh, I'm not trying to steer people to a certain thing. Hey, have you heard that drinking 3 cups of coffee a day doubles your chance of having a heart attack? I guess I'm got a double chance of having a heart attack. I've already had multiple cups of coffee today. In fact, though, if you read some of the articles, and I link the articles, and it's kind of funny, if you look at the first one linked, it basically says what I said, basically drinking multiple cups of coffee a day doubles your chance of having a heart attack. But if you read the one from the American Heart Association, the heading is less misleading. It says, drinking 2 or more cups of coffee doubles your chance of having a heart attack if you have severe hypertension. Of course, I don't like how they say that either, because you have to know what severe hypertension is, but at least that's a little bit more accurate. But if you read either one of these articles, they never talk about the absolute risk. They just say doubles. They talk about relative risk. Well, what does that mean? What does doubles mean? Does that mean I'm a lot more likely to die, or just a little bit more likely to die? If with no caffeine, if there's a 1% chance that I have a heart attack, and with 3 cups of coffee a day, there's a 2% chance, that might change my decision making. Well, I like coffee, I need it. 2%, versus 1%, I'm not so worried about. Now, you think that's kind of a funny example, but some of you may have heard about the UK contraceptive scare in the 1990s. So in 1995, the third generation of the pill came out, birth control pill came out, and but there was a increase in the amount of thrombosis or blood clots in the lungs, and it increased, double, basically twofold. And so this information was passed to Dear Doctor letters by the pharmaceutical company, and of course that leaked out to the media because the goal was to get this information out. And so the news caused great anxiety, and distressed women stopped taking the pill, which led to unwanted pregnancies, according to this Ferrendi study or Frady study, 800 additional among girls under 16, and an estimated 13,000 additional abortions. So think about how just saying twofold or double the risk caused problems. But the problem was, how big is 100%? Studies had shown that thrombosis occurred in 1 of 7,000 women who took the second generation contraceptive, but that number increased to 2 of 7,000 women who took the third generation pills. So the absolute risk increase was only 0.014%, but the relative risk increase was in fact 100%. So, but what's scarier? Well, if you take this third generation, you've got a 0.014% chance. Not that anybody would know what that means, but it's going to increase your risk from 1 in 1,000 or 1 in 7,000 women to 2 in 7,000 women. Well, now, obviously, if you risk benefit, the benefit of having of taking that pill is probably going to outweigh not taking any pill at all. And so, and again, of course, that was the problem, right? Is that, we saw the studies is that people stopped taking any version of pill, and you had the additional, pregnancies and abortions and all of that. So that's obviously a really cautionary tale type example. That doesn't come up all the time. So what we also know, let me go to this first. What happened after the alerts? Again, you can see the chart is that, people reversal of downward trend of the number of abortions in England and Wales following that 1995 pill scare. It increased it a lot. And so that's obviously was not the intended outcome, but it was the outcome. So what do we know? We know that patients overestimate the benefits and underestimate the risks. But what can you do about it? That's the other question is, we can understand this tendency and use it to have honest conversations about the benefits and harms of screening, of the procedure, test, or screening. So I think about the conversations, the education, are the ions. You think about ions of health education. You got to have conversations, education. And in order to do that, it's not just one or the other. It's both. And lawyers might not allow you to skew the language one way in a document. So the conversations are the key, when you're actually talking to people about the risks, knowing that people might overestimate the benefits and underestimate the risks, you can kind of push that, you can kind of use that tendency to your advantage to explain more things. So relative risk versus absolute risk. Hold on one second. Carter, get Lulu. All right, so relative risk, by not taking this medication, you won't have any side effects, but your risk of having a stroke will double. Versus absolute risk. If you don't take this medication, you won't have any side effects, but your risk of having a stroke will increase from 5 to 10%. So that's what often says. Don't be fooled. It's all relative. You'd rather present this in a way that says, okay, here's what's going to happen. 5 of 10 people or 10 of 100 people might have this problem. It's going to go up from 5 of 100 to 10 of 100, or 5% to 10%, or something like that, versus double, triple, quadruple, whatever it might be. Using visual aids is important, right? They help reinforce and reframe messages. Too much information is still a problem. It's got to be a good graphic, but icon arrays, and pie charts and graphs, those can all work, but they have to make sense intuitively. The University of Michigan created iconarray.com, which is a free site to create the little icon arrays, which is 1 of 4 people and those type of things. So I use that all the time when I'm creating documents. This can take up a lot of space for larger numbers, like 1 in 1,000. So it doesn't work well for that. but it can work well with like 1 in 10 or 1 in 4 and those type of things. But when you start getting over 100, it kind of gets kind of difficult. So pie charts and graphs will work, but they need to be simple and intuitive. So for example, think about this one. About 1 out of 10 women improve their symptoms using this medicine. So this was medicines for treating urgent incontinence. So this type of stuff works better. You can look and kind of see the difference. Versus to the right, you need like the Rosetta Stone to figure out how to interpret that. Nobody's going to look at that and say, oh, where am I? I'm in Humboldt County. Which one is kind of gray? Let me figure out what that means. So you got to think about the graphics. This is a good one that I like from the National Institute of Health. You can still have the percentages, but also adding, look for the heart to find the healthier choice. So, and then again, these little green arrows, choose more often versus choose less often. So again, you can present this in a lot of different ways, but thinking about a thoughtful way will be more important and more helpful. So some takeaways on all of this. Well, focus on the main concept in absolute risk. Use natural frequencies, X out of how many people, absolute risk versus relative risk. The key being patients need to understand that there's no certainty and no zero risk, but that risks are more or less acceptable. And again, a lot of times you can cover that in conversations. Screening can have risks and benefits. Again, we saw that from one of the from the mammogram example. So, providers and patients need to realize the cost, inconvenience over treatment, false positive and negative, a lot of those things. And questions, you think about questions patients should ask. And if they don't ask, and you're kind of the provider, you can kind of lead in with these. What's the risk? The risk of what? Dying? No recurrence? What's the time frame? How big is the risk? What do these studies mean to me in my demographic, if you're giving me this? What are the benefits and harms of treatments? How strong is the evidence? We know people don't think like that, but that is a helpful way to present things. So now there's a post presentation QR code. If you take a few seconds to do that, again, use your phone and kind of and take a picture of that and put my name in there. And I think it's 1 question. And then now we'll move into questions, but I wanted to have that up there before I stop sharing the screen and move back to the main room. But thank you everybody for having me, and I'm happy to answer questions about this. So if you're done with the QR code, feel free to to ask questions either in the chat or come off mute and ask questions. Happy to start doing that, and then I'll stop sharing the slides here in a minute.
Thank you so much, Chris. That was really great. The only issue is that I think there's so much here, and it's such rich and such intriguing content that it leaves you wanting more, which I guess is a good way to land.
Yeah,
here,
there's
right?
a lot that happens with numeracy. There's so many different things to think about. So, that's why I like what you've already been doing with the training and learning about other health literacy concepts and organizational health literacy versus individual type things, because it all goes hand in hand. It's just, it's like a piece of the puzzle. You need more than one thing to make it done right, to do it well.
I think that's a really good point. Just what you closed with about, like, if people don't ask about the obvious thing they should be asking about, that's a verbal thing that we should make sure we bring up in our conversations, and we can say things like, a lot of people ask me about how, what the chances are that X would happen, if they don't bring that up. And that's obviously, maybe from our perspective, something that's really important for them to know and to understand. And of course, that's how where and why we use Teach Back.
Right, and that's exactly right. The Teach Back stuff is very helpful there. And so that's kind of, it gets a little controversial because I tend to harp on that a lot if I talk about this a lot more, as like, we should be putting these thoughts in people's heads. And other folks that I talk to, like risk managers and all that, well, we don't want to put thoughts that shouldn't be in their heads, but I'd rather have you do that before this happens than have something happen that they don't expect. And then what happens if people do if something happens that they don't expect? they might start seeing a lawyer in the first place. Say, this happened and it didn't expect, happen the way I thought. Did they do it right? But if you already are explaining things and taking the time to do that, they're less likely to think that there was a problem. So I think being proactive is really helpful.